Hello, so this presentation aims to understand Boyle's law and its relationship with ventilation of lungs. This is a topic that I actually enjoy talking about and discussing because it relates to my favorite hobby, which is scuba diving. I use this example a lot when I'm introducing this topic of Boyle's law to my students. So it's one of the reasons why I chose this topic this week. What will we cover over the next 10 to 15 minutes will be an introduction to Boyle's Law, what are the pressures involved in the lung and the ventilation of the lungs, how does pressure affect ventilation. We're going to look at a case report from a freediver who suffered from pulmonary barotrauma. And lastly, a study that researches ventilation between simulated altitude and actual altitude and how those differ between each other. So, Boyle's Law, what is it and why is it important? So, there are multiple variables that are going to affect gases like air. So, these variables include temperature, volume, and pressure for the most part. And so, Boyle's Law states that at any given temperature that remains constant, the pressure applied by a gas within a closed container will have an inverse effect on the volume of that gas. So, what that means is for a gas at any given constant temperature, if our pressure increases, the volume is going to decrease, and vice versa. If our volume increases, that tells us that the pressure exerted on the gas will decrease. So this is that equation P1V1 equals P2V2, right? So that is Boyle's law in mathematical form that tells us that pressure and volume are inversely related. And our lungs are a closed container. And so we experience this idea of Boyle's law within our lungs all the time, every time that we breathe, because we experience a change in volume and pressure, which is brought on by respiration. Here's a nice picture of that P1V1, P2V2, right? Here, our volume has increased. There's more space here. That pressure has decreased because there's more places for those molecules to go. Here, right, we have increased pressure. We've added either weight or taken away volume, right here. We can see that there's more space, or I'm sorry, less space for our same amount of gas particles to interact with each other, so that pressure is going to increase. So, under pressure, what are the pressures found within the lungs and outside of our lungs that are very important in ventilation? So, air is going to move down pressure gradients throughout the respiratory cycle, and there are three types of pressure that are very important when considering ventilation. The first is atmospheric pressure, which is the pressure that is going to be applied to pretty much everything on the surface of our Earth, because it's the pressure that we feel from the weight of the air within our atmosphere. And so this is actually going to decrease as we increase in elevation. So as we get further away from the surface of the Earth, atmospheric pressure is going to decrease. And as we get further, I don't want to say to the surface of the Earth, but as you increase in depth, so if you go further underwater, that pressure is going to increase. The second type of pressure is intra-alveolar pressure, and it is the pressure that exists within the alveoli. And alveoli are just tiny little air sacs that are clustered together at the end of our bronchioles, and this is where gas is going to be exchanged between blood and the air. So these are really important parts of our lungs when it comes to breathing. And so our alveoli connect with the atmosphere through our conducting pathways. So our trachea, the things that bring air into our body. So air will quickly travel down its pressure gradient anytime the intra-alveolar pressure is not the same as the atmospheric pressure until the two become equal. And that'll make more sense as we get into inhalation and exhalation. The last type of pressure is intrapleural pressure, which is the pressure within the pleural sac. So unlike intraalveolar pressure, intrapleural pressure is exerted exteriorly from the lungs. However, it's still inside the thoracic cavity. This is because the pleural sac is a closed environment in itself, meaning that air is not going to flow into or out of it due to a pressure difference, either within the atmosphere or within the intraalveolar pressure. It's like its own little closed container of pressure. And here we see a nice simple diagram of what the lung would look like. Here's our airway entrance, our trachea or whatever, going into the intraalveolar pressure area. This would be like the lung or the alveoli sac. Here we see the intrapleural pressure in blue, how it is almost a separate closed container. And then obviously atmospheric pressure exists outside because it's existed on the atmosphere. And this section right here is just the boundary of our thoracic cavity, showing you that all of it exists inside of that thoracic cavity. So, when I was doing my research, this idea of transpulmonary pressure kept popping up. And it is this idea that ventilation is going to be dependent on the differences within those pressures that I just mentioned on the previous slide. So, transpulmonary pressure is the difference between intrapleural and intraalveolar pressure. So, inside the lung and then inside the pleural sac. And it's going to determine the size of the lung. So, an increased transpulmonary pressure would cause the lungs to be larger, and this pressure is caused by the intraalveolar pressure equilibrating with atmospheric pressure because they always want to be the same. So, it's going to make the intrapleural pressure greater, or it's going to be greater than the intrapleural pressure. I'm sorry. So, it makes sense like this, right? Intraalveolar pressure is greater than intrapleural pressure. However, it is still equal to atmospheric pressure. This causes more pressure to push out than the pressure that is pushing inward, causing the lungs to push outward, stretching, and then ultimately increasing lung volume. The intraalveolar pressure rests at about 760 millimeters per mercury, while the intrapleural pressure is about 756 millimeters per mercury. So this 4 millimeter per mercury difference is the transpulmonary pressure gradient, and it doesn't really shift from this. So it's going to push the lungs out, filling the thoracic cavity, and we don't tend to see this transpulmonary pressure gradient change all that much during ventilation. So inspiration or inhalation, those two are interchangeably, is when airflow is going to increase the lung, right? So airflow always is going to travel down a pressure gradient, just like chemical concentrations and things like that. So the intraalveolar pressure must be less than the atmospheric pressure in order for air to flow into the lung. This is what is happening during inspiration or when you are breathing in. When you breathe in, your intraalveolar pressure starts to decrease, and so pressure wants to travel down its gradient. And this is ultimately the result of a muscle contraction. So it's kind of interesting to think that your lungs don't fill up with air because you're breathing in necessarily. They're filling up with air due to the muscle contraction. So that is why this phase of ventilation is considered active. The muscle that contracts is the diaphragm. And so what's going to happen is that thoracic cavity is going to increase in volume. And so due to Boyle's law, if volume increases, that tells us that pressure will decrease. So this increase in volume is what's going to cause the intraalveolar pressure to decrease. Right? So now our pressure is not the same as the atmosphere. That's what we see in this dip right here. Our intraalveolar pressure decreases. It is less than the atmospheric pressure. So air is going to flow into the lung. Air is going to continue to flow into the lung until that pressure gradient exists no longer and we start to reach equilibrium with atmospheric pressure and intraalveolar pressure. During this phase of ventilation, our intrapleural pressure decreases slightly. That's down here. We see this decrease slightly because the lungs are stretched out, so they pull away from the thoracic wall. In expiration, the other side of ventilation, all right, so that air that enters our lung needs to leave somehow. And expiration is how our lungs achieve this. This is known as the relaxation phase of ventilation because the diaphragm is going to relax, our thoracic volume is going to decrease. And Boyle's law states that if volume decreases, our pressure is going to increase. So if volume decreases within the chest cavity, the intraalveolar pressure is going to increase, which is going to push air out of the lungs. The flow of air out of the lungs will stop when the intraalveolar pressure is equal with the atmospheric pressure. Once again, there would be no pressure gradient there, so it's going to stop pushing air out. However, there is this idea of active expiration, and this is needed when you need to either empty the lungs more or you need to empty the lungs at a faster rate. And so, to do this, the intraalveolar pressure has to increase above the atmospheric pressure. That way, that pressure gradient is larger. And this is achieved by our expiratory muscles, such as the diaphragm, the intercostal muscles between your ribs, and then your abdominal muscles as well. So those muscles are going to contract more, which is going to further decrease the volume within the thoracic cavity or your chest cavity. And so this would make the difference between the intraalveolar pressure and the atmospheric pressure greater. So more air is going to leave down its pressure gradient before equilibrium is reached. Intrapleural pressure is going to exceed atmospheric pressure here, but our lungs aren't going to collapse. And this is due to that transpulmonary pressure gradient that I mentioned earlier because that gradient still exists. And this is because the intraalveolar pressure also increased here. So our lungs are going to stay stretched and fill the thoracic cavity, and we're still going to stay around that 4 millimeters per mercury gradient. So here's a nice diagram of what I kind of just explained, right? So here we have inspiration, or right before, our atmospheric pressure and our intraalveolar pressure are equal, and we still see that 4 millimeter per mercury difference here. What's going to happen is we are going to increase the volume. So our diaphragm, which would usually exist down here, is going to billow out. Our lungs can expand. And so our volume has increased. So our pressure inside will decrease, causing air to flow down its concentration gradient. That is your inhaling portion of ventilation. And then once that is reached to equilibrium, right, that air's got to go somewhere. So your muscles are going to start to relax. Your diaphragm's going to start to go back to its resting place, making that volume smaller, volume decreased. Boyle's law says that pressure has to increase. That is what we see right here. When that pressure increases, that air's got to go somewhere. So it's going to be expelled out through the air pathways like your nose and your mouth until we reach that equilibrium of 760 again, and we're back towards the front over here. So these are the case reports that I was talking about. So pulmonary barotrauma, simply meaning that there's trauma in the lungs due to pressure, is something that normally occurs with scuba divers. It's not something that's uncommon. However, we don't love it to happen. It's not something that's unheard of because the pressure is obviously going to increase when you descend into the ocean or any body of water. However, this is only usually a problem if air is trapped during your ascent back to the surface. So when pressure is decreasing, volume is increasing, or when you hold your breath due to pressure at depth and the volume within your lungs, all these things can cause pulmonary barotrauma. That is why the number one rule in scuba diving is never hold your breath, and that comes in handy in this case report. So this case report looks at a diving incident that resulted in barotrauma. The authors of this report look at the timeline of events. They reviewed chest CT scans, diagnosed the patient, and then explained the reasoning behind the trauma. So this relatively healthy 36-year-old male was free diving to a depth of roughly 9 meters, and he dove down multiple times. Free diving, meaning he didn't have any scuba gear attached to him. On his fourth dive down, he found his dive buddy who was attached to scuba, and so the patient inhaled compressed air at a depth of 9 meters and failed to exhale that extra air on his ascent to the surface. So, according to Boyle's law, the pressure decreased on the ascent to the surface, so the volume of air increased, and because he inhaled extra compressed air down at depth, there was more air in that chest cavity and it needed to escape somehow. So, it escaped involuntarily before reaching the surface. The patient complained of chest pain and sensory changes at the surface. A chest CT was conducted, revealing emphysema. And so, when you're in normal breath holding, you're just free diving down, the volume of the lungs will decrease because of ambient pressure increasing when you go further and further into the ocean. However, on the ascent back to the surface, your volume will return to its normal state while pressure is decreasing. That's why if you're free diving in a pool or anything like that, you're not at risk for barotrauma because it's just the air within your lungs, right? As long as you're exhaling and inhaling, your lungs will return back to normal. And this is because no air is added to the space when you're changing your pressure and your volume. So it would be like taking a water bottle with a cap on, right? If I just took a normal water bottle, put the cap on, it was full of air. I went down to 100 feet in water. If I took that water bottle out of my wetsuit or whatever, that water bottle would be completely crushed at that depth, right? I didn't do anything to the water bottle. I just took it down 100 feet. And that was because our pressure increased. And that tells us that our volume would decrease. And so without touching the water bottle again, as I start to ascend back to the surface, that pressure is decreasing. So volume is going to increase and my water bottle returns back to its normal physical state. This is what happens with your lungs, right? So, however, when air was inhaled at depth, the pressure in the environment is greater. So, if you do not exhale on your way up, the added volume of air has nowhere to go except out, causing barotrauma. And so, this picture here is a picture of this guy's CT scan. You can see the emphysema, the extra air within his chest cavity right here, and it causes immense chest pain, and it's really not a fun thing to have. So while I was doing my research, I found a article where they looked at peak flow and ventilation at high altitude versus simulated altitude in normobaria. So simulated altitude is used often to study physiological hypoxia responses due to altitude. However, there have been differences in responses between simulated altitude and altitude conditions. And this study decided that they were going to look at this at a further detail. So they hypothesized that the resistance to air compression at expiration should be lower. Expiratory flow and peak flow should be higher in hypobaric hypoxia. So this is high altitude at like the tops of mountains that we're actually going to, rather than at normobaric hypoxia, which is simulated altitude. And so this group performed a spirograph in normobaric hypoxia at different simulated altitudes, and then the corresponding altitudes were also performed with a spirograph, and they did 6 healthy subjects, so they only did 6 test subjects at 2 different altitudes, 2 altitudes simulated and 2 altitudes actually on a mountain. And so let me explain the results a little further. First, the subjects would perform a spirograph in normobaric hypoxic room with a simulated altitude of 2,800 meters after each subject hiked 7 hours on a treadmill. So they formed that spirograph, they let the subjects rest for 2 months, And then the same subjects repeated the spirograph in a hypobaric hypoxia state. Um, and so they climbed Mauna Kea in Hawaii. They climbed the hiking trail and did a spirograph at 28,000 meters and 42,000 meters. And so the results actually showed an increase in ventilation during exercise, so during the hiking. It showed increased breathing frequency and increased peak expiratory flow in the um, hypobaric hypoxia, so the blue in this graph. This is what it was actually hiking Mauna Kea in Hawaii. Right, we can see that it was increased for both elevations minus oxygen uptake, which I will get to in a minute. So while these two increased, oxygen uptake actually decreased by about 2% in hypobaric hypoxia environment. The same parameters were compared at 28,000 meters, and we see the same, almost same to little difference between the two testing environment. So the red would be simulated altitude and the blue would be true altitude. You don't see much difference at this elevation. We really only see difference at 4,200 meters. And at zero altitude, there was pretty much zero difference except in the volume. So they decided to leave that off this graph. So this graph on this slide shows mean ventilation, the breathing frequency, and oxygen uptake at both altitudes of 4,200 meters and 2,800 meters. Breathing frequency was increased for both altitudes, for both the normobaric hypoxia and hypobaric hypoxia, as I just discussed earlier. Ventilation was increasing drastically at 4,200 meters within the hypobaric hypoxia environment. However, at 2,800 meters, the difference was barely noticeable. Oxygen uptake is the only one where the normobaric hypoxia was superior at both altitudes. So oxygen uptake actually improved when it was in a simulated environment. So these results help to support the theory that a lower intraalveolar pressure is due to the lower air density at elevation, which results in a lower resistance and breathing frequency as well. So these are my sources. Hope you enjoyed my presentation.